Good afternoon to all, but also good morning and good evening to many of us. It is our pleasure to welcome you to the ITM Alumni webinar organized in light of World Malaria Day. In this webinar, ITM PhD alumnus and researcher of the Clinical Research Unit of Nanoro, CRUN in Burkina, will share the research findings and results of the development and clinical evaluation of the vaccine candidate R21 Matrix M, which is currently being developed by CRUN, the Clinical Research Unit of Nanoro, one of ITM's long-standing partner institutions, in collaboration with their partners at the University of Oxford in the UK. The main aim of the ITM Alumni webinars is to share research findings, expertise, and experiences on a specific international health topic within the ITM community of alumni, students, staff, partner institutions, and the wider global health community. I will now briefly explain some of the webinar practicalities. If you want to ask a question, you can use the Q&A option you will have below your screen. You can ask a question anonymously if you would choose to do so. The chat is being disabled for questions. Questions will be moderated and only a select number of questions can be answered in live given the limited time. Unanswered questions cannot be answered individually afterwards, for which we apologize. At the end of this webinar, a short survey will be displayed and a browser window will open to give your feedback. The webinar is being recorded and will be made available afterwards on the ITM Alumni platform and the ITM YouTube channel. Our today's moderator is Dr. Ula Maniewski-Kellner. Ula is a registered internal medicine physician and infectiologist specialized in travel medicine and tropical medicine. She's working at the ITM Travel Clinic. In the past, she worked for MSF and gained extensive experience in low resource settings. As an expert, she's coordinating many aspects in the field of travel medicine, from guidelines, malaria country maps, courses, specific working groups to the ITM travel website. And she's also the co-chair of the Belgian study group of travel medicine and is a member of NITAG for vaccines. Ula, the floor is yours.
Thank you very much for your kind introduction. And I'm very happy to present Mr. Magloire Natama. He's a biologist and he is currently appointed associate researcher in the clinical research unit of Nanoro in Burkina Faso. He's also a PhD. He has a PhD in biomedical sciences from the University of Antwerp in partnership with ITM, the Institute of Tropical Medicine. And his research interests include vaccinology and malaria immunology, malaria during pregnancy and its effects in infants, and genetic factors and susceptibility to malaria. He's author and co-author of several publications in these fields in several medical reports. And he's also the coordinator of the phase 2 and 3 clinical trials on the R21 malaria vaccine candidate at CRUN. And this way is going to talk about today. So, Mr. Natama, the floor is yours now.
Thank you very much, Ula. I'm going to share my screen. Okay. So this is a great pleasure for me to share with you what we are doing in Nanoro in Burkina Faso in terms of malaria vaccine development. And this today I'm happy to present this the findings of the R21 malaria vaccine, and this presentation is entitled Insight into the Development Progress and Clinical Evaluation of the Candidate Malaria Vaccine R21 Matrix M. This year, the celebration of the World Malaria Day has a special flavor because we are in a new era in the fight against malaria, with the announcement by WHO in October 2020 of the recommendation of the first malaria vaccine, RTSS, for children living in endemic settings. So what we know about this first generation of malaria vaccine, RTSS, also known as Mosqueris, is a vaccine targeting the pre-erythrocytic phase of the life cycle of the parasite in human, and it's targeting the circumscribed protein, which is a protein of the parasite before it enters into the liver. And this vaccine has been evaluated in the phase 3 trial between 2009 and 2013 in 11 sites across 7 African countries and involving more than 50,000 children aged 6 to 12 weeks of age and 5 to 17 months. So overall, this vaccine showed an efficacy of 36% after the administration of 4 doses over 48 months. And for children aged 6 to 12 weeks, there was a weak efficacy compared to that of the 5 to 17 months. And in these children, the vaccine efficacy was 56% over 1 year follow-up. So then why WHO is recommending a vaccine with such a modest efficacy? So first of all, it's because malaria burden is still extremely high, with more than 229 million cases occurring worldwide, with 93% of the cases observed in Africa. And 70% of the total cases occurred in 11 countries, including Burkina Faso. And these cases are causing more than 400,000 deaths, 94% in Africa, and 67% in children below 5 years. The second reason is that when we look at the current malaria control strategies, that include the case management with rapid diagnosis tests in remote settings, and also artemisinin combination treatments that really help to manage very well the cases in endemic countries, the preventive treatment for specific group, intermittent preventive treatment with sulfadoxine pyrimethamine for pregnant women, and seasonal malaria chemoprevention for children below 5 years, and also the use of long-lasting insecticide-treated nets. There have been a significant decrease of malaria cases between 2000 until 2015. And as we can see from 2015, there is a stagnation of malaria decline, highlighting the limitation of the current tools used to fight against malaria. So that's why WHO recommended implementation studies with the RTSS vaccine. So the implementation studies were conducted in 3 countries, in Ghana, Kenya, and Malawi. And within 2 years, more than 2.3 million doses were administered to more than 800,000 children. And they conclude that RTSS vaccine could be delivered through the existing platform of the childhood vaccination that reached more than 80% of the children. And they also took advantage of that implementation study to assess some safety concern that was observed during the phase 3 trial, because there were some meningitis cases among RTSS vaccinees, but there were also more severe cases occurring in girl compared to what in boy. So during these implementation studies, they actually confirmed that this was not the case, and that's why they were positive for the recommendation of the RTSS. There was also another implementation study where they combined RTSS with the seasonal malaria prevention, and that was conducted in Burkina Faso and in Mali. And compared to the seasonal malaria prevention alone, RTSS combined to SMC showed an efficacy of 62%. So there is an increase of the efficacy. The efficacy against the admission with severe malaria was 70%, and against malaria death 72%. And compared to RTSS alone, we have similar efficacy rate with 60% against clinical cases, 70% against the severe malaria cases, and 72% against malaria death. So now, going to this promising new candidate malaria vaccine R21. So first of all, it's good to know that R21 is quite similar to the RTSS because R21 is also a pre-erythrocytic candidate vaccine targeting the same antigens, which is the circumscribed protein. And here we can see that the vaccine is using a portion of the non-repeat region, which is here, and the sequence of the C-terminal region. And this sequence is used both in RTSS and in R21. So the first difference is that in RTSS, for the configuration of the particles, they use two sequences of the antigen HBS of the hepatitis B virus. So for the configuration with the same sequence number amino acid. And for the R21, they only use one sequence of the HBS antigen of the hepatitis B virus. So this ends up with a configuration of the particles in R21 with a significant representation of the CSP antigen on the surface of the particle compared to that of the RTSS, where there is an excess of the antigen HBS of the hepatitis B. So in addition, in R21, the HBS antigen is lowly immunogenic, while in RTSS is highly immunogenic. Another difference between the two vaccines is that R21 is using an adjuvant, which is a saponin-based adjuvant, matrix M, while in RTSS, the adjuvant used is a liposome-based adjuvant. And the saponin-based adjuvants have been shown to have an advantage over the liposome-based adjuvant in inducing both humoral and cellular immune responses. So before we started the clinical, the phase 2 trial in Burkina Faso, there were some evidences of R21 immunogenicity, safety, and efficacy through preclinical studies where R21 showed high titers of non-specific IgG with matrix M with an efficacy of 87 to 100%. But also in clinical trials, the first one in a phase 1/2A trial, which was a challenge study where R21 demonstrated a very good safety profile, high non-specific IgG titers, and a vaccine efficacy ranging from 73 to 78%. In a phase 2A study, that was an age de-escalation study in adult children and young infants, R21 showed a very good safety profile and a very high antibody responses to IgGs with a highest being in children and infants with the dosage of 5 micrograms of R21. So then it's in this context that in 2019, we started in Nanoro, Burkina Faso, the phase 1b/2b trial to assess the safety, the immunogenicity, and efficacy of R21 matrix M in 5 to 17 months for children in collaboration with University of Oxford, where researchers developed the R21, and Serum Institute of India, where the vaccine is produced, Novavax producing the adjuvant matrix M, and in collaboration with EDCTP, the finder. So the primary objective was to assess the protective efficacy against clinical malaria of R21 matrix M in 5 to 17 months old children, 6 months after the 3rd vaccination. So what we consider as the primo vaccination. And there were a couple of secondary objectives. The first, to assess the duration of the protective efficacy against clinical malaria 12 months after the primo vaccinations, the protective efficacy against asymptomatic infections, to assess also the safety and the reactogenicity 12 months after the primo vaccination, and the humoral immunogenicity against the CSP 12 months after the primo vaccination. There were also some exploratory objectives to assess the protective efficacy against severe malaria cases 6 months after the administration of the final dose, which was the first 3 vaccinations, and also the cellular immunogenicity and other exploratory immunological endpoints, and also to assess the possible role of the microbiome in determining optimal vaccine responses in the recipients. So the study was conducted in Nanoro, in Burkina Faso, in West Africa, and that was implemented in Nanoro Health District, where we have a health and demographic surveillance system. So the study was implemented within the HDSS catchment area, and the villages where the study was implemented was Sum, Nanoro Godo, Poissy, and Segedin and Nazwanga. So in this area. So this was a double-blinded randomized trial in which 450 participants were randomized and allocated to 3 groups, group 1, 2, and 3. Group 1 and 2 received R21 matrix M, with the difference between the 2 groups, the dosage of the matrix M. So it was 25 micrograms of matrix M in group 1 and 50 micrograms of matrix M in group 2. And the group 3 received the control rabies vaccine, Rabivax. So as I said, the primo vaccination consists of a series of 3 vaccinations with 4 weeks apart and a booster dose 1 year later. So we screened 498 participants, 471 were eligible, and at the end we included, we enrolled the 450 participants. Most of them were aged 12 to 16 months, and there was also a good balance between male and female. The first vaccination was on May 7, 2019, and we completed the primo vaccination on August 7, 2019. And 450 received the first doses, 445 the second dose, and 442 participants the 3rd dose. And 1 year later, between June 2nd and July 2nd in 2020, we administered the booster dose, and 410 participants received the booster dose. So looking at the safety in terms of local adverse event, we assess pain, redness, and swelling. And for each of the graph, we can see that for each parameter, the data are presented for group 1, 2, and 3. And also for each of the adverse event assessed, they were graded in terms of intensity to mild, moderate, and severe. Mild in gray, moderate, dark gray, and black for severe cases. So we can see that for vaccination 1, there was few participants who experienced the local adverse event assessed. We can see that the less than 10% of the participants experienced these events, and the majority of the events were mild to moderate in terms of intensity. And we observe similar pattern for the vaccination 2 and 3. In vaccination 2, we have a slight increase to 50% for some of the local adverse events like swelling, but in general, there were similar pattern of these local adverse events. Regarding the systemic adverse events, we assess fever, irritability, drowsiness, and loss of appetite. And here also, these events were graded in terms of intensity, similar to that for the local adverse event. And here we can see that fever for vaccination 1, 2, and 3 were the most common adverse systemic adverse event reported. The majority of them were mild to moderate in terms of intensity, but we can also see that participants in group 2 who receive higher dose of the adjuvant matrix M experience more fever than participants in group 1 who receive also R21, but also compared to that of the control group, the group 3. So in terms of efficacy, so this was efficacy 1 year after the first, and looking at the first episode. And also we consider different definition of clinical malaria, and the primary definition was fever, national temperature of 37.5 or hysteroid fever during the past 24 hours, and a parasitemia more than 5,000 parasites per microliter. And here we have the cumulative incidence of clinical cases for participants in group 2, in group 1, and in the control group. And 34% of the participants in group 1 experienced at least one episode, 26% of the participants in group 2, and 71% of the participants in group 3 experienced at least one episode. And looking at the vaccine efficacy assessed as per the hazard ratio calculated by Cox proportional models, vaccine efficacy was 69% for participants in group 1 and 77% in group 2. Looking at the multiple episode, participants in group 1 experienced in total 75 events, 60% in group 2, and 250 events in group 3. And the vaccine efficacy was 70% for group 1 and 75.7% in group 2. We also assess the number of malaria cases averted by R21 matrix M, and that was 1,393 averted cases per 1,000 child in group 1 and 1,523 averted cases per 1,000 child for participants in group 2. So now looking at the immunogenicity, there was the first analysis using blinded data where we observed that 2/3 of the participants responded to the vaccination, looking at the non-specific IgGs. And following unblinding, we observed that those who responded were participants in group 1, who received the lower dose of the adjuvant, and participants in group 2, who received the higher dose of the adjuvant. And the geometric mean of the titers was 11,000 for participants in group 2, nearly 2 times higher compared to that in the group 1, which was 6,000 ELISA units. And in this graph, you can see the kinetics of the non-specific IgGs from the primo vaccinations. We have here the line for the participant in group 3, the control group. Here, the kinetics of the antibodies for participants in group 2, in group 1, sorry, and the last one is for participants in group 2. So as we can see, 28 days after the primo vaccinations, there was a high titers of non-specific IgGs, and they peaked to the level for participants in group 2 to nearly 12,000 and 6,000 for participants in group 1. And the titers decreased at a low level 6 months later, and more 12 months, 1 year later, by the time we're administering the booster dose. But as you can see, after the booster dose, the levels increased to levels similar to that was observed after the 28 days after the third vaccinations. And looking at the association between non-specific IgGs and vaccine efficacy, we pull the participants in group 1 and 2 and divide them in titers regarding non-specific IgG titers, and participants in the upper versus the lower title has a reduced risk to develop clinical cases with a nasal ratio of 0.24. And when comparing participants in the upper with participants in the middle title, those in the upper title have a reduced risk with a nasal ratio of 0.46. Because we completed now the 2 years follow-up, I'm showing here the total severe adverse events that occurred during the 2 years follow-up. We have 10 in total, and male and female were both affected by the severe adverse event at different age, and they were from in the 3 groups across the 3 study groups. And here we have description of the cases. We had meningitis cases, severe anemia and severe pneumonia. We have some severe malaria cases, and also some severe bronchiolitis cases. And we have 8 of them which were resolved, and we have 2 fatal cases, and also these severe adverse events occurred at different time points from the vaccinations. So in conclusion, we can say that in terms of safety, the majority of the adverse events were mild in severity. There was no withdrawal due to safety concern. We observed high-level efficacy with 3 doses of 5 micrograms and the higher dose of the matrix M at 12 months. We observed very high responses to NAM, and this may be a correlate of protection as shown by the the association assessment with the efficacy. The immune responses were boosted well with the fourth dose, and an expected high level of efficacy during the second year follow-up is awaited. And this efficacy, we now completed this 24 months efficacy, and we are preparing the manuscript for the publication. And I can say that during the second year follow-up, the vaccine efficacy was maintained as expected with the high titers of antibodies after the booster dose. So taking all these findings, R21 has the potential to be the second generation of malaria vaccine, reaching the WHO specified goal of at least 75%, as stated in the 2016 and 2030 new growth targets and milestones. But before we reach to the recommendation of the R21, the vaccine need to continue its evaluation in the field, and we have different perspectives regarding the next steps. The first is that for the phase 2B trial, we extended the participant follow-up to assess the long-term efficacy of R21 and to assess the added value of boosting R21 vaccinees once per year prior to the malaria transmission season. And to this end, participants were randomized in subgroups in group 1 and 2. And the subgroup are group 1A and 1B in group 1 and 2. Those in group 1A and 2A will continue to receive R21, while those in the 1B groups and 2B, they will now receive the control vaccines. And then there will be a second and the third booster dose each year prior to malaria transmission season. And the group 3, the control will continue to receive the control vaccine. The second perspective is the phase 3 trial, for which 5 sites in Burkina Faso, Nanoro and Dande. There are 2 sites in Burkina Faso, one in Mali, Bagamoyo in Tanzania, and Kenya are now implementing the phase 3 trial. Because for the phase 2 trial, there was only 1 site, Nanoro, where we have a seasonal malaria transmission. So now there is a site where malaria transmission is annual. So therefore, we differentiate sites to implement the standard vaccination and those to implement the seasonal vaccination, as we did for the phase 2. And in total, 4,800 children aged 5 to 36 months have been recruited in all sites. And taking into consideration the vaccine efficacy in the group 2 observed in the phase 2, so the dosage of the vaccine with 5 micrograms of R21 and 50 micrograms of matrix M is being used in the phase 3. And the seasonal site started last year in April, May. So this is to show the study design for both the standard regime and the seasonal regime. So there will be a primo vaccination of 3 doses 4 weeks apart. And so participants in the standard regime will be recruited throughout the year and will receive the vaccines schedule as stated here, with a booster dose when there is 1 year follow-up. And for the participants in the seasonal regime, Nanoro and Buguni, so we will do exactly what we did in the phase 2. We will administrate the primo vaccination prior to the high transmission season, and then the booster dose 1 year later, again, prior to the high transmission season. So we completed the 6 months follow-up in the seasonal site in February 2020, and we will have soon the primary result from this phase 3. So the other perspective in terms of R21 pre-qualification is that WHO is being helpful in accepting a submission for both the pre-qualification and the policy recommendation by 30 September. By this time, you will have a result of the phase 3, but also result from the phase 2 with the second year follow-up data, but also after the extension with the second and the third booster dose data. And it's possible that a lot of vaccine could be supplied next year. Another perspective in terms of R21 future deployment is that our provision is to produce hundreds of millions of doses of R21 at a few cost, few dollars for the cost, and this normally should alleviate the great supply problem that RTSS is facing, because only 7 doses a year are foreseen for the RTSS. To finish, I would like to acknowledge the study participant and the parent for the collaboration and the involvement for the implementation of these trials in Burkina, the study teams in Nanoro, at the University of Oxford, and also our collaborators from the Serum Institute of India and Novavax, and also EDCTP. This is what I wanted to share with you, and I will be happy to take some questions. Thank you very much for listening.
Okay, thank you very much for your interesting presentation. So everybody feel free to post your questions in the Q&A. Natama, I have already a question for you.
Okay.
A first question about the study design. So if I understood correctly, in the groups being studied, you compared the booster doses with another vaccine with for rabies, but that was in combination with all other preventive measures that are normally adopted in Nanoro, meaning like bed nets and also seasonal chemoprophylaxis, or not?
Yes, this was implemented like in real life, because we didn't try to control what is in place in Burkina in terms of control strategies. As you mentioned, there is a seasonal malaria chemo prevention for children under 5 years, and also bed nets that are distributed. So we didn't control this. But since this was a randomized trial, so both group, the vaccinees group and the control groups are comparable.
Okay, and do you have any idea that maybe a bit outside your presentation about the coverage of seasonal malaria in that region?
Yes, the coverage is quite high of the seasonal malaria chemo preventions, but unfortunately, in some districts, it's even reaching 100%. And what is really the matter of the current tool is that during the last 3 years, for instance, in Burkina, we still have 11,000 of malaria cases per year. And those occurring in children below 5 years are it's where we have higher numbers of cases, while they are supposed to be protected during the seasonal malaria TB prevention campaign during the eye transmission season. So there's really a problem with current tools implemented in Burkina and even in other endemic countries.
Then I see a question in the Q&A, which is also one of my questions. And even though it's not the objective of the study, but as M21 is also containing a part of hepatitis B S surface antigen, but just one, not the three that you use in RTSS. Yeah. Does it also offer any protection against hepatitis B?
Yes, in RTSS, it does, because it's, as I mentioned, it's highly immunogenic, and they even conducted a separate trial where they assess the immunogenicity of the antigen HBSS component, and it provides a significant protection. But in R21, we didn't assess it in the trial yet, but from the experiment, it's really lowly immunogenic.
Okay, and that is because of the lack of these three other hepatitis B S antigen, which is not used in R21, but which is part of the RTSS.
Exactly. Yeah.
Okay. Then I have another question from the audience. Is there any reason why RTSS was not used as a comparator?
Yes, because by the time we started the R21 phase 2 trial, RTSS were still evaluated in the implementation studies and were not yet recommended. So, but now, since it's recommended, future vaccine trial will probably use RTSS as a comparator.
Okay. And then I see another question from the audience. For phase 3, why don't you plan to come to Kimpese in DRC, where they have a well-developed IDSS?
Yes, there were other studies, other sites who participated in the phase 2 trial of RTSS, but for R21, we were not able to include all of them. So we actually try to have site for seasonal malaria transmissions. So Nanoro, where we did already phase 2, and Buguni in Mali. And in the two sites, there will be a controlled SMC administration in the phase 3 to also a way to address your first question. And in Nanoro, we'll continue the administration of the vaccine without controlling the SMC. And then for the peri-annual site, there's one in Burkina and the other one in East Africa, to also have at least two regions in Africa, the West and the East, to compare the vaccine efficacy in these populations.
Yeah, that is also a bit one of the next questions. If you have any research being done with other types of malaria or other strains, or any results so far, both falciparum, different strains, but maybe non-falciparum as well?
No, actually we are, the CSP protein is specific to Plasmodium falciparum, so the vaccine is designed to protect against falciparum malaria. And so we also plan to assess the variability of Plasmodium falciparum strain in the vaccine efficacy. And so that will be done to see, but not for other species.
Okay. And do you have any results about the effect of the vaccine on sickle cell trait study participants?
Sorry?
Do you have any, did you see any difference of efficacy of the vaccine in people with sickle cell anemia or with sickle cell traits, so carrier of a sickle cell gene?
No, this was assessed in the eligibility criteria to see if there is some participant, to know if there are some participant who has a sickle cell disease. But we have really very few cases, but it's planned that we assess later if the genotype, the hemoglobin genotype could affect the vaccine efficacy. But from what we know from the beginning of the study, we have few having this.
Mm-hmm. And have you studied, or has it been studied, any other ways of administration? I suppose this one was intramuscular, but yeah, maybe other means of vaccinating has been studied?
No, we didn't explore other vaccination type.
Okay.
Mm-hmm.
Well, at this moment, there are no other questions in the Q&A. I don't really have any other questions either. It was very clear and very interesting. Yeah, maybe just one, but it's maybe difficult to answer. Yeah, I think the whole world was happy that at last the first vaccine can be used now. Now the other vaccines in the pipeline. In best case scenario, when do you think, or when could we expect it to be implemented?
Let's say in the best case scenario is that we have confirmed high efficacy of R21 in the phase 3, and that we have we take advantage of the process that has been used to speed up the vaccine development related to COVID, to quickly register the vaccine and have the pre-qualification and have the recommendation by WHO. So then maybe within a year, 2 years time, the vaccine could be available. And what is interesting is that Serum Institute of India are really working in that way to be able to produce a lot of doses as soon as we have all the green lights.
Okay. And the reason why, if everything goes right and it leads to implementation production, why it is possible to, well, produce so much vaccines in a short time. Okay, can you elaborate a bit on that?
Possibly that because Serum Institute of India has been involved now since a couple of years in the production of this vaccine, and also Novavax, who are producing the Matrix M, are collaborating with Serum Institute of India in the way that even to produce a one vial of the vaccine, so already because now we have 2 different vials, R21 and Matrix M, and they are working to have a single vial, and we are assessing if we have similar immunogenicity when using 1 vial and the 2 vial in Mali now. So all these results will give us information and guide on how the vaccine could be developed quickly and by Serum Institute of India.
Mm-hmm. And does the vaccine need a cold chain? Does it need?
Sorry?
Sorry, does the vaccine need a cold chain? Do we need to keep it in the fridge, or is it possible to store it outside or at room temperature?
No, it's at 4 degrees.
Okay.
Yes, and that is also very important for the deployment to have a vaccine that could be stored similar to the EPI vaccine for children.
Okay. There's another question coming. If you have any knowledge about the acceptability of a 3-dose regimen plus booster, is it well accepted by people outside study conditions?
We didn't assess yet this outside the study because so we are not there yet. But within the study, we have a good perception with the retention rate within the trial, even after 2 years for the extension. Those who resigned to continue were for family reasons because they were traveling, but we really have a good retention rate within the trial. And the second indicator could be for the phase 3, because we, from 450 participants in the phase 2, we recruited 1,200 in Nanoro for the phase 3. And the recruitment was within 4 weeks, the 1,200 participants. So, yeah, people were really keen to be part of the trial.
Okay. I don't know if there are any other questions. I see there's another one appearing. Yes, do you have any idea if this vaccine will be adopted about how much it will cost?
There is not yet a number, but yes, as I said in my presentation, University of Oxford and Serum Institute of India think that it could be available at a very low cost, comparable to what, because already for the design of the vaccine is quite cheaper than what was required for the RTSS, and also the dosage, because it's 5 micrograms of R21 and 50 micrograms of matrix M. So the dosage is not also high. So that's, let's think that for the production will be at a very low cost.
Okay. And do you think this vaccine could be useful as well for other type of persons, thinking of, for example, pregnant women and maybe completely different travelers?
Yeah, so far evidences are from children. And so if there will be a recommendation, it will be like for RTSS for children below 5, and other evaluation of R21 are in the pipeline for adults, but for pregnant women, not yet, because it's completely different with the immunopathogenicity of malaria during pregnancy. So not yet.
Okay, yeah, and for travelers anyway, a vaccine in 3 doses with a booster is not very interesting either.
Yeah.
And the WHO recommendation for Musterix was clearly for infants living there and not for travelers.
Yeah, exactly.
Okay. I'll have a last look if there's any other. There's still a question. The long-term efficacy. Yeah. How long should it be to be acceptable? And yeah, of course, what we don't want to see is shift mortality to a higher age. So therefore, we do need indeed a very long time protection rates.
Yeah, that's why in the we implemented the extension study of the phase 2, and where first we want to see with the first 4 doses, how long the children could be protected. And we are also able to assess if each year for seasonal site, it's needed to boost again the children. So we will have at the end a complete data of 4 years follow-up to assess that.
Okay. I don't see any more questions.
No, indeed, I don't think it's there is another one, but maybe voilà, from Itzi. Maybe we should take this last one, and then we can round up.
Okay, well, so from Itzi, it might be worthwhile to apply for an ETC or ECTC certificate from WHO, which would allow the vaccine to leave a cold chain for a specific time in a specific temperature right before administration. And that could be useful to improve usability in the field, was what he's thinking.
Sorry?
So if you could get a specific certificate that you can take out a vaccine out of the fridge for a certain time, but that needs to be studied, of course, for how long you can keep it outside the fridge before administration to make it more easy to use in real life. Yeah,
no, for the phase 2 and the phase 3, the vaccine should be administered within an hour. So this is even with the 2 vials of one of matrix M and one for R21. So now we are working to have 1 vial. So that will be in terms of implementation and storage matters to be, because they will not have a procedure to prepare the vaccine before administration. So that will be really helpful in terms of vaccines storage and the time from taking out from the fridge to the administration. So that's why I was mentioning that it's really good to have a malaria vaccine with a storage condition similar to that of the extended program of immunization for children, so that it will be managed similarly.
Okay, thank you very much. I think we're running out of time. Just to say a big thank you to Natama for sharing the insights on this promising candidate vaccine. Also to Ula for the moderation of this webinar. And as well to Yves for his always very valuable technical supports. Thank you to the audience for attending and also for completing the poll, which is now popping up on your screen. And of course, we look seeing you back for one of our next upcoming alumni webinars. In the meantime, stay safe and healthy, and looking forward to seeing you again. Thank you.
Bye-bye. Thank you very much.
Thank you. Thank you to all.
It was a great pleasure.
Thank you.